Thank you very much for letting me present our data today. I'm a PhD student working in Udeson with circulatory support in cardiogenic shock. The topic today is how concomitant vasoactive treatment affects LV function and organ perfusion in a cardiogenic shock model supported by an impella CP. What is the clinical relevance of testing concomitant vasoactive treatment in cardiogenic shock supported by an impella? If you look at the evidence for both mechanical and medical circulatory support, there's a level of evidence 2B, which means that it might be considered in cardiogenic shock. The level of evidence is very poor. The use, this is from Denmark, a 7 years trend in the treatment of cardiogenic shock following acute myocardial infarction. What you should notice is that there is an increasing use of impella devices, but the rate of use of vasoactive treatment is stationary and used in about 90% of cases. So, in the clinic, what do you do if you have a cardiogenic shock patient that has low perfusion pressure and you have already inserted placed an impella CP? Do you add an inotrope or do you add a vasopressor to increase perfusion? And what to choose to avoid increasing the left ventricular workload? I have listed 4 commonly used vasoactive agents, which is epinephrine, dopamine, and norepinephrine. They all stimulate both beta and alpha adrenergic receptors, causing vasoconstriction and increasing contractility. And you have phenylephrine as the last drug, and it only causes vasoconstriction. So we thought we wanted to compare these drugs and their effect on pressure volume area and cardiac work, which is pressure volume area multiplied by heart rate. This is the product, the total work of the heart. And then we would look at the renal and cerebral saturation and the lactate. And it is in 10 pigs with ischemic cardiogenic shock on the support, impella support. On the day of the experiment, we had a 70 kilogram pig anesthetized and intubated. This was Danish landrace pigs. We made multiple accesses. What you should notice is we had a Miller's conductance in the left ventricle to measure pressure volume relationships. Then we had a Swan Ganz placed in the kidney vein to access saturation in the renal vein, and we had a retrograde internal catheter in the internal jugular vein to assess cerebral saturations. Then we were ready to induce the shock. We did this by stepwise microembolization into the left main coronary. This was done 1 milliliter at a time, mixed with the isotonic saline and contrast, and until we were in a profound degree of shock. Shock was defined as mixed saturation less than 50% of baseline or less than 30%, and our sustained cardiac index under 1.5 for at least 10 minutes. What you see on the x-axis is the fraction of microspheres in total, and you see the cardiac index and the mixed venous saturation declining as we inject the microspheres. When the animal was in shock, we started the impella for full flow. And this is just to show you the protocol. We had the instrumentation, we had the development of shock, and then we had the impella turned for 30 minutes. Afterwards, we had data acquisition. If mean arterial pressure dropped below 50 milligrams of mercury, we initiated a small dose of norepinephrine to keep the mean arterial pressure about 50. Afterwards, we were ready to do a blinded crossover protocol, which was either norepinephrine, epinephrine, or dopamine for 30 minutes each, a data acquisition during each 30 minutes, and afterwards we started the phenylephrine as last dose. Phenylephrine has a very long half-life, that's why it wasn't blinded. There was no washout between infusions, but as these drugs has very short half-life, we don't consider that a problem. At last, the animal was aerosolized. To account for time, we used statistic. We used the linear mixed model, taking time into consideration, and also the intervention and the pig as a random factor. We used the reference point, which was the impella CP time. And now we're getting to the PV loops. You have all seen that before. This is a pressure volume loop from one of the pigs, a normal pig. When we induce the shock, you'll see that the loop goes rightward, and there's a decrease in contractility. This you have seen before. When we initiate the impella, you'll see a more triangular shape of the loop, and you will see that the loop goes leftward as signs of unloading. What we are measuring is the pressure volume area versus the potential energy and the stroke work, and we want to compare the time of the impella with the infusion that we're giving. This is from one pig, and if you see how norepinephrine affects the loop, the stroke work increases and the loop goes a bit more left. This was even more pronounced with dopamine. Epinephrine There was a similar effect, but not that pronounced. And if we look at the vasoconstrictor, there was a trend toward going to the left and increasing end diastolic pressure. The statistic, this is the result from all of the peaks. If you look at the x-axis, you have the phases of the study, and on the y-axis, you have the fold change compared to Impella, which is the red dotted line. So if you start with the baseline, that is when we start the study, then we have the shock phase and the Impella. And this is heart rate, so there were no change in heart rate from Impella at baseline and shock. As we give epinephrine, dopamine, norepinephrine, and phenylephrine, the heart rate changed, but not significantly for norepinephrine. But there was a big increase in heart rate on dopamine and phenylephrine. This was heart rate. Left ventricular end diastolic pressure increased in the shock phase and decreased during the Impella therapy. If you look at phenylephrine, it also increased, but else there was no significant increase. LV stroke work was the active work that the heart has to perform in each loop, increased on all drugs, but not phenylephrine. Pressure volume area also increased on all drugs compared to the Impella state. And then we look at the total work that the heart has to perform. It increased on all the drugs, but not significantly on norepinephrine, and there was a big increase for dopamine. The organ perfusion, see that the cardiogenic shock phase, it's really low perfusion, and then we start the drugs, the Impella, the perfusion increases. As we start the drugs in epinephrine, norepinephrine, and dopamine, there is an increase in mixed venous saturation, and phenylephrine caused a decline, also compared to the Impella state. Arterial lactate, there was a significant increase at the phase of phenylephrine, and there was a trend toward lower lactate with norepinephrine. Renal venous saturation, there was a decline for phenylephrine, but else there was no significance. And the cerebral venous oxygen saturation increased during dopamine, else there was no significance. So what is the clinical implication of this? If we look at the total work the heart has to perform, the workload seems biggest during dopamine and phenylephrine and norepinephrine to a lesser degree, and it was not significant. And if you look at the arterial lactate, there was a significant elevation with the phenylephrine and trends toward lower lactate during norepinephrine. So if perfusion pressure remains low during Impella support, you can consider using norepinephrine as first choice, as it has both mild inotropic effect and a potent vasoconstrictor effect. And you should avoid using phenylephrine, which only has a vasoconstrictor effect. And that was all for me. Thank you very much for letting me present. This is my colleagues. If you have any questions, feel free to ask.
Thank you very much. Any questions, comment?
Nanna, thank you for that very clinically relevant approach. We've been kind of preaching the use of norepinephrine as a gestalt, but now you provided some wonderful clinical evidence, so really want to congratulate you. I'm a little confused about why norepinephrine wouldn't increase lactate. Without a doubt, phenylephrine is like bad. I believe what you're saying, but it also, if you have a potent vasoconstrictor, why wouldn't you decrease peripheral perfusion and therefore increase arterial lactate when you use norepinephrine?
So you're asking why the lactate...
Your lactate levels drop or were with norepinephrine infusion, and I don't quite understand why. Is it because you're getting more forward flow? Because if you have constriction of the periphery with norepinephrine, you would expect tissue hypoperfusion and an increase in lactate level.
Yeah, but you also, norepinephrine also increases contractility, so you'll also have an increase in contractility, whereas what you see for phenylephrine, and I didn't expect that, I expected that it would look much better because the heart wouldn't be pushed that much because the contractility doesn't increase on phenylephrine, but that's not the case. But the norepinephrine has both effects, so I think that's why.
Nanna, thank you for that very elegant set of experiments. Am I right in thinking that the infusions of these drugs were without Impella support, or was Impella support still ongoing?
Oh, sorry, yes, the Impella support was running all the time. That's a very important thing.
And so, do you feel like the Impella was supporting the ventricle enough with these therapies? I mean, the phenylephrine PV loop was quite striking. I guess we were chatting. We weren't sure the impella was actually on during the
Yeah,
experiments.
it was on all the time. It was you're testing these drugs concomitant with the impella, so it was yeah.
And was it a set dose then that you gave for each one of these drugs, or was it titrated to some hemodynamic endpoint?
They were titrated, so they should be equal. It was dopamine and phenylephrine was 10 microgram per kilos, and norepinephrine and epinephrine was 0.1 micrograms per kilo. Mm-hmm.
Yeah, that's really great. Ryan and I were talking, and really stimulated a lot of discussion. One of the questions, so with the phenylephrine alone, just based on the PV loop, I mean, the contractility actually increased in response to just the phenylephrine. So that's the acute load imposed, even with impella in place. So I think there's a little bit of a competition there, right, between the imposed load from increasing afterload that would drive innate contractility versus the unloading effect. But with the norepinephrine, I guess the other question is whether or not you're getting a selective vasoconstrictive effect. So as opposed to getting pure alpha vasoconstriction throughout the body, do you think that the norepi, one of the advantages there and the reason why you may not see the lactate spike is due to a regional perfusion of organs is still preserved? So is there a way, or have you thought about using systemic microspheres to look at, for example, renal perfusion in the setting of impella plus norepinephrine?
Well, we have not considered that, but it's, yeah.
I mean, that just may explain some of the differences between just a pure alpha vasoconstrictor versus norepinephrine, and its impact in different organ beds may actually explain the lactate.
Mm. I didn't.
So pressure generation went up, right? And the DPDT went up, right? If you go back to the loop, yeah. Blue is on the drug, right?
So probably the contractility didn't really, the main effect is on the afterload. The other point is, about these, conducting this after is tricky, everyone that's using it knows how tricky this is, the calibration, minor changes, and, I just wonder whether, there's slight changes in the parallel conductance here cause loops to shift one way or another. So my interpretation of this anyway would be primarily the phenylephrine didn't really, the main effect there was afterload, and preload. Preload is really, really pronounced there, and it's not on the contractility.
Yeah, no, I agree with you completely, Dan. I think the primary effect is load, right? But the question I guess I'm looking at is this peak of LV systolic pressure generation,
Yep.
right? So the LV responds to that load
Yep.
by maximizing its LV systolic pressure as much as it can. So I think that's where, again, my takeaway message was that even though you have an increased vasoconstrictive afterload effect, the ventricle still has to respond to that. And so this may be why you start to see expansion of injury, for example, if this was an AMI model.
Yeah, absolutely.
Right,
So that was going
phenylephrine
to be my
effect.
question, was about what's going on with the ventricle.
Right.
So the focus here has been on the periphery, perfusion, but the ventricle is
Still
another story.
responding. Yeah, exactly.
But I have the results from the ESPVR. That's only when we analyze all the animals, it's only dopamine causing a significant elevation increase. Yes.
Congratulations to these nice results that have an impact clinically. My question is about the right heart. We focus our attention here on the left ventricle,
Yes.
but if you look at lactate, for example, hepatic clearance of lactate also depends on venous outflow of the liver. Right ventricular coronary perfusion also depends on heart rate, on arterial pressure. So there is some black box in your data still which may explain parts of these differences. Do you have some information about the right heart in this experiment, or is this something for the future to do?
I actually have information about the right ventricle also. What's your question?
So the question is if there are data about the right heart, which we have
Yes,
not
we
yet
have-
seen
we
in
have-
the
we have-
results, and would be interesting and maybe helpful to explain some of these differences despite our focus on the left ventricle that we see here.
I didn't want to confuse you, but we had also had a conduct sense that took place in the right ventricle. But it's a bit challenging, I think, to analyze those. But my colleague is doing it now.
Jacob Muller, I participated in the studies. I think one of the reasons why the contractility seems to increase is also that these animals were in so profound shock and they were extremely hypotensive. So increasing the pressure would also induce recovery of some of the stunned myocardium in the non-infarcted areas due to a perfusion pressure that was mean pressure was less than 40 in most of the animals when shock was induced. And to comment on Patrick's comment, we did see on the pure vasoconstriction, we did see quite marked right heart failure. So the CVP, the right atrial pressure, went up and the pulmonary pressure went up as well. So a lot of the vasoconstrictor effect, I think, is due to right heart failure.
I'd like to congratulate you on your study. This is a perfect example. I'm right here. Sorry. Perfect example of translational research and how this can really help us clinically. My question is, as a surgeon, one of the things that in the clinical world that we are faced with is, at what point do we increase our mechanical support in a situation like this? So we have a patient that comes back from the cath lab with a CP device in, who's on escalating doses of these pressors that you're studying. My question is, have you done any bench studies to compare the CP with these agents, norepinephrine or dopamine or epi, with increasing the flow using a 5-liter device instead of the CP device, or is that something that you've considered doing in the future? Because one of the hypotheses that we have is that the fewer medications that we can have these patients on, the better they're going to do overall. So the question really is, at what point do we increase our support so that we don't have to be on these medications? Do you have any thoughts on that?
I think it's a really good question. I think your strategy is very good because you want to avoid these drugs. But the problem is we are looking at a cardiogenic shock patient after acute myocardial infarction. So we have to intervene very quick, and often there isn't a surgeon just near, or it takes a bit more time. So you are in a crash burn situation where you want to use the drugs. But I think that if you can place an Impella 5.0, it could, I think probably it would be much better. But I think in the clinic and when you have a STEMI, it's not possible just to do it like this. But I think it would be very interesting to compare Impella CP and the drugs with the Impella 5.0.
Thank you very much.
Thank you.